All right, good evening, everybody. I hope you can hear me loud and clear.
Yes, Grandpa.
We start our third week lectures. Now, as I've tried to put on the platform, we shall have our first exams on Tuesday. I'll be unavailable for lectures tomorrow and tomorrow, Friday, and Saturday. So use that period to do your own studies to learn some of the things that you've learned already. And the exams will cover what we've done from the beginning up to today, what we shall do today. And I'm sure all of you will have good week. So still on common penile conditions, functional defects, disease, and disorders that affect the penis. Like we said, you're going to take them organ by organ, and we are still working on the penis. All right. The previous week, we did a lot of discussions on erectile dysfunction. And to be able to appreciate erectile dysfunction very well, you must understand how erection itself occurs, so that I want to bring to your attention, you call it now, Penile disease is a type of erectile dysfunction which occurs when scar tissue develops inside the penis and causes the penis to bend or curve unusually. And we have it that a slight curvature is normal. You know, especially penis, and also for this, it causes some injury to the penis. And you know, for those injuries, the penis will try to heal on its own. For all injuries where there's healing, there's also scar formation. So you have the scars forming within the penile shaft, and in that scenario, it causes the penis to curve or to bend. Now, the scars produce what we call a plaque. It's like if you have a normal wound on the skin and it heals, look at the scar that forms. It may be big enough if it happens inside the penile tract, and that will cause the penis to bend a little bit. So that bending, when there's an erection, then it creates a problem for the individual. So we call it penile disease. It is usually due to persistent or repeated penile injury. All right. And as students of andrology, you have to know something about it. as we move along, we're going to talk about the Cody's disease, where it is not due to injury, but the patient or the individual is born with a curved penis. That's quite different from the Penile disease. The Penile disease, it is as a result of injury. The injury could come from several forms, either through accidents or through some physical activity, especially children who play in schools. So there was a slight break from my end. So we're talking about erectile dysfunction and then the Penile disease, which is saying that is due to a curvature. And the curvature is as a result of persistent or repeated penile injury, either through an accident or through physical trauma or anything of a sort. And also, it usually occurs in childhood. Now, when you're a child, and like I've said over and over again, so many times, if there's an injury, that may have occasioned through some physical activity in school. Many times when they come home, they don't even tell their parents. And that's one of the things that will, in the long run, cause the injury which happened to the penis to create this what we call a scar. And the scar will become big enough to form what we call a plaque. And in that case, it tries to bend the penis. Now, it appears not, but to the extent that it can cause some sort of discomfort, for that matter, pain during erection, now gives it, makes it a disease condition. All right. Right. So this is the Penile disease. And you can see from here, let's see. From here, this was a scar, which has become big enough to form what we call a plaque. And that will tend to bend the penis. Now, so want to be straightened. I'm sorry, I think today I'm going to have challenge with my network. All right. I hope you can see my screen now. All right.
Yes, you can see, Doc.
Okay. So this is what happens with the penile disease, where there's a curvature due to a scar. Right. And it can cause penile shrinkage, it can cause penile shortening. All right. Instead of because during erection, you want the penis to now be elongated because of the scar. It makes it difficult for you to get a full strength, and therefore it appears to give you a shortened penis. All right, good. Right. So the penile disease may bend up, down, or either side on erection. So this is just a pictorial presentation. It can be up, down, left or right, whichever way. So that's how it is. Right. Then we come to the cont, the CHO, we pronounce as cause, like cholera. Okay, so cont. So this one is quite different from the penile disease. Penile disease is somehow, how do I call it? It's accidental, all right. But the cont is a congenital. So where the child is born with it, a curved penis. Now, the curvature is strong enough. It's not like a small curve. Like we said earlier, any small bend is normal to the extent that it doesn't cause pain to individual during erection. It is nothing to get worried about. It poses no medical condition. But when the curve is severe to the extent that it can cause pain during erection, then it becomes a medical condition. Like I've said, if it is as a result of some injury, all right, then that becomes the penile disease. When this curvature is congenital, the child is born with it, then it becomes the cont. All right, so that's the difference. One is congenital, one is not. All right, so that's the big difference. Now, so take note, as students of andrology, sometimes you are talking about some of this so that you may have a parent or even you yourself have a child with some of these conditions, then you know how to handle them. Or somebody may come to you for an advice that I have my child who has this. You have the knowledge to be able to now explain or counsel the individual. Oh, this is normal to the extent that it doesn't cause any pain, or the child been born with it. Sometimes if it's too curved to the extent that it can in future affect sexual activity, then you go to the andrologist or the urologist where there can be some surgical interventions. All right. Now, so it is very important to know that the cont, that's a curved penis, I mean, from birth, is contraindicated for routine circumcision. If the child is born with that sort of curved distance, please don't advise circumcision. It's better, especially those circumcisions that are done in the homes, right? It could create a problem. Right. We are saying so because even though the cont is technically congenital, born with it, however, if you do circumcision, you don't do it right, it can end up giving you the cont. I hope I'm not confusing you. The cont is supposed to be congenital, it's born with it. All right. Now, however, if a child may have an inherent cont which is not exhibiting, and you do circumcision, which is not properly done, then it will complicate it and now develop a full-blown cont. I hope the point is very clear. So if you notice any curvature in a newborn and you're going for circumcision, please advise that they take the patient or the child to the hospital so that it can be properly managed by people who know what to do, rather than encouraging the home-based circumcision. I hope the point is very clear. I've said that the cont itself is technically a congenital. However, it can happen as a result of complication in circumcision. Right. Right. So now let's look at some ejaculation problems. Now, this is very simple. Reduce ejaculation. We know a lot about ejaculation. When ejaculation is less than, when you go to semen analysis or seminology itself, you know that the WHO put the lower limit of ejaculate volume. That is, if you ejaculate is the whole amount of semen which comes out is ejaculate. Now, the lower limit as by WHO is 1.5. So if somebody is producing less than 1.5 or even less than 1 mil, then that is called, it is described as hypo. You know, hypo means below. Spermia, that is the spermia here is not talking about the sperms, but rather talking about the entire ejaculate. So hypospermia is reduced semen output or the semen ejaculate. I hope the point is clear. Now, common causes of low ejaculate volume. And then we've highlighted retrograde ejaculation. So we are going to talk about retrograde ejaculation in full. So when you have retrograde ejaculation, you're going to have lower volume of the ejaculate or reduced ejaculation, right? You could also have physical obstruction somewhere in the reproductive tract, so that along the ducts, if there's any obstruction there, then it could also influence the volume that comes out. There's also be congenital bilateral abscess or the valve difference. We talk about all this in full if, let's say, we're talking about the abnormalities associated with the valve difference. But for now, when you have congenital bilateral absence, it means that the patient is born or the person is born with it bilateral, all the two valve difference are all absent. So if they are all absent, then you can imagine that the volume of semen which will come out will be severely affected. Past history of surgical intervention in the urological system. So if you have had any history of surgical intervention, especially in the bladder area, it could also affect the volume of semen which comes out. And then androgen deficiency. I mean, talking about testosterone, low testosterone, and then diabetes mellitus. Diabetes has a lot of effects on the male reproductive system, especially on erection and this thing. You know that we've realized that ejaculation, erection are all influenced by the neurons. Okay, so you have a neuron effect, and you know that diabetes affects or damages the neurons to a large extent. You know, you have diabetic neuropathies. Okay, so neuron diseases associated with diabetes becomes diabetic neuropathy. So once you have this scenario, it means that ejaculation and for that matter, erection will also be affected in situations of diabetes. Right. So one of the things that makes reduced or hypospermia problematic is that when you have that small volume which comes out, remember at the end of the day, we want the sperms to go in to fertilize the female egg. And the system does everything to protect the sperms. But if you have low ejaculate volume, then because it's small, in the vagina, it's likely to succumb to the vaginal acidity. Remember, if you have large volume, remember we talked about the coagulation and so forth and so on. So because the volume is large, they also coagulate. These are all mechanisms that try to protect the sperms. But if the volume is small, irrespective of the coagulation and everything, they will still succumb to the vaginal acidity, and therefore all the sperms will be killed in the vagina. All right. So then there's also this fact that when you have repeated ejaculation that is always giving you low volume, then you can think about a condition we call retrograde ejaculation. Retrograde ejaculation. So our next topic is going to be on retrograde ejaculation. So what I'm saying is that if the individual is doing semen analysis and then he ejaculates, and then the first ejaculation produces volume which is very small, well, you may want to repeat. If let's after 2 weeks you repeat and the same volume is coming out, you should know that there's something wrong. So it's like when, and like we said, there are a lot of causes, but one of the major causes be the retrograde ejaculation. If let's say somebody has fever, I think one of the first causes you may want to consider is malaria. So you may have to rule out malaria first before you could think of other things. So if you have low volume of semen, one of the first things that we want to consider would be retrograde ejaculation. And so we're going to look at our next thing, which is retrograde. Before we go to the retrograde ejaculation, I want us to have an overview of the mechanism of ejaculation. We've talked about ejaculation extensively, but for the purposes of understanding retrograde ejaculation, I want us to do an overview of the mechanism of the ejaculation. You know, in ejaculation, there are two things that happen: emission and ejection. Emission is like massing up the entire semen, massing up and putting them at one place. And then ejection is now pushing them out. So it is, you must first and foremost put them together. Remember, you see that when we are, even though we haven't done the seminology, but from all the discussions that we have done, at least we know that we have the sperms are produced from the testes, they get stored in the epididymis, and then they push along the line and sometimes get to the ampulla, and then they can now even push to the seminal vesicles. Seminal vesicles is also going to provide something. All of them will now come to the prostate area, all those. So it means that there are so many areas that are playing roles in the semen production. So emission is trying to put all of them together. You are coming here, you are coming here. Okay, all of us, let's come and down a mass, or let's get ourselves ready here. All right, so that's the emission. And then ejection is now, okay, now you are already go out, then you push them out. All right, so that the whole mechanism of ejaculation takes place in two forms. The emission, that's the gathering of all the individual components and put them at one side, and then the next system will be the push them out. That's the mechanism. And so emission consists of the sequential contraction of the epididymis. Remember, before all of them can pull together, there should be contraction. And remember, we've also said that the sympathetic nerves will now cause contraction, if you remember from the previous discussion. And then parasympathetic is parallel, relax. They will cause relaxation. And for that matter, that is where we talked about the ejaculation. We said that in ejaculation, the parasympathetic nerve will play a role because the relaxation. Once there's relaxation, then what do you call it? The arteries will now be open up because they have relaxed, they open up, and then you can have this since the blood pushing them through. However, if there's contraction, you need energy. Remember, we said that sympathetic activities is energy consuming. They need energy. So to contract, you need energy. So emission ejaculation is caused by the sympathetic nerves or the sympathetic nervous system. All right. So that is what happens, and gather all the products from the epididymis, the vas deferens, and push them all together at the prostate urethra. All right, let me go back a little bit. Okay, so here I'm saying that sympathetic nerves control the emission process. Now, because it's about sympathetic, there's contraction. So once emission is bringing all the products to the prostatic urethra area, then it means that there must be further contraction at the neck of the bladder. Because remember that all these things will come to the prostate. And within the prostate, you also have the urethra also coming from the bladder. So there should be a force that will hold the neck. And this is our contraction. Because the our contraction is sympathetic. So that's how you should understand the whole principle. All right. So then the ejection. During the ejection, the neck will still have to be closed. Now there's also what we call urethral sphincter. During the emission stage, both the urethral sphincter and then the bladder neck are all closed. Then at the ejection phase where they are now going to push out, the bladder neck is still tight, and then the urethral sphincter become loose or relaxed to allow the entire seminal fluid to go out. So during the ejaculation, the semen is not coming out. It's like, how do I? So the whole thing is coming from up from the testicles to the vas deferens, all have you. They come to join at they come to accumulate at the prostatic urethra there, and now they are coming out. So it's like everything is coming out in a forward motion. So we call them antegrade. So what we are saying here is that the process by which normal semen is produced and then comes out from the prostate to the urethra to the outside is called antegrade, forward movement. Okay, grading is like movement. So anti is forward. So anti-grading is forward movement. So the entire ejaculation is a forward progression. All right. So now, if that's the case, then so this is how it is. The antegrade, that's forward movement. So during ejaculation, semen is propelled forward through the urethra and out of the tip of the penis. And this is known as antegrade ejaculation. Now, when you talk about ejaculation, you don't bring the antegrade because like it's a common thing. I mean, it's like you say forward march. I don't know how to describe. It's like it is well known that ejaculation is a forward movement. All right. So whether you bring the antegrade or not, it's like an inclusive thing. Okay. So that's why we don't bring the word antegrade. But technically, the antegrade is an adjective qualifying ejaculation because it is something that says that the thing is coming from up, down, outside. Okay, so it's a forward movement. And let me see. So from here, coming up, down, 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 out. This is the antegrade. Now, let us now look at retrograde. Retrograde. Retro means backwards. I'm sure you talk about retrospective study. You talk about retrospective study. You're talking about something which has happened already, and you're going to look back. You are going to go back and look at it. So retro means reverse or backwards. All right. So when you say retrograde ejaculation, remember we said that normal ejaculation should be a forward movement or antegrade. So if it's now going to be the opposite, the retro, then there should be something wrong. Of the normal ejaculation that we know about. Let's see how it is called, how it happens. So it's a condition whereby all or part of the semen flow backward. And if semen flow backward, where do you think they will go? They will go into the bladder. The semen is coming from the vas deferens to the ejaculate to the prostate. All right. And they are supposed to come out. So if they are going to go backwards, they are not going to go backwards up to the, let's say, ejaculatory tube or the ejaculatory duct, or for that matter, seminal vesicles. They won't go there. So we talk about least resistance. So if they are going to go back, then the path of least resistance will be to the bladder. I hope that you are getting the point. You want to, any movement will always go through the path of least resistance. So if there is going to be a condition where the semen, instead of coming out, is have to go out, you have to go backwards. Then the backwards, the least resistant area will be to the bladder. So they'll flow into the bladder. All right. And so during sexual intercourse, the bladder neck, like we said, have to be closed. Now, if they close, then it means that the semen have no chance of going backwards. But if something has happened and then there's a problem with the closure, then they'll go back. And once they go back, where will they go? They'll go into the bladder. So therefore, retrograde ejaculation is a system where the semen, instead of coming through the urethra and out, will now have to go back into the bladder. So retrograde ejaculation happens when the bladder sphincter or bladder neck muscle fails to work properly. Remember, we said that it should tighten or it should be closed. If there's a failure in that mechanism, then the semen will flow backwards, okay, into the bladder instead of going out through the urethral penis. So this is how it is. I think a better picture is here. So here, the semen, instead of coming all the way through the prostate to the urethra and outside, will now go back into the bladder. So in retrograde ejaculation, the muscle that shuts the bladder does not function normally. This allows all or part of the semen to travel backwards, retrograde, into the bladder at the time of ejaculation. So let me see. On top, can it cause retro pressure and causing retrograde ejaculation? There's a problem with the bladder neck closure. All right. If the woman sits on you and you are still ejaculating, it will still go. It will still go, except that instead of it going to the cervical area, there's a likelihood of the semen coming out. Okay. In coming out, they don't come out and re-enter into the urethra and go back into this. No, they will come out of the woman. I hope the point is clear. So retrograde ejaculation has nothing to do whether the man is on top or the man is down. All right, I hope I've answered your question. So retrograde, they're talking about normal ejaculation is termed as antegrade, forward movement. Now, that can happen only if the bladder neck is closed. If for any other reason the bladder neck fails to close, then it allows the semen to move backwards. And moving backwards will go into the bladder. All right. Now, it depends on the extent of the closure. If the thing is let's say the bladder neck has to close, but it doesn't close properly. There's a small, let's say, if there's a small loose ends of it, then it means that not all the semen will go. It means some will go and some will still come out. That's what we call partial retrograde. So let's see the next stage. So there is no, let me see. I think I've missed. Okay. Let me go back. All right. So, sorry. Retrograde ejaculation can be partial or complete. Partial is when we are saying that the mechanism of retrograde ejaculation is influenced by the inability of the bladder neck to close. If the closure is partial, and let's say it is closed but not fully closed, then some of the semen will move into the bladder, some will also come out. And so that's where you have reduced ejaculation volume, right? Now, if the closure is so loose that it is almost open, then it means all of the semen will go into the bladder and nothing will come out. And that is what we call dry orgasm. Remember, orgasm is associated with what do you call it? With ejaculation, because it is that kind of pleasure, all right, that will actually stimulate the ejaculation. So even the orgasm and ejaculation are two different things, but they happen almost together. All right. So orgasm is a sexual pleasure. And then it is that which will now also force the semen out. And the force of the semen out is ejaculation. So you see that orgasm and then ejaculation appear to be going hand in hand. All right. So now there's orgasm, you want semen to come out, yet the semen doesn't come out. So you call it dry orgasm. Okay, dry orgasm. And it is also called aspermia. A means absence. The other day we talked about prefaces of certain medical terminologies. So absence of spermia. So there's nothing is coming out. That's different from the situation where the closure was partial. So when the closure is partial, then some of the semen will go into the bladder, some will also come out. So in that case, you are going to get some semen out, but that volume will be small. All right. So that's where you have the issue of hypospermia or reduced ejaculation. And so in that case, your conclusion will be a situation of partial retrograde ejaculation. If the closure is so, if the bladder neck is so open, then once it's so open, everything will go into the bladder and nothing will come out. And so the person will have a sense that, oh, I've had orgasm. I've got a feeling that I should ejaculate. Meanwhile, that is coming out. That's what we call dry orgasm or aspermia. So in that case, semen volume will be zero. What it means that everything has gone into the bladder. That's what we call complete retrograde ejaculation. So if there's small volume coming out, you can't call it complete retrograde ejaculation, because if it were complete, nothing will come out at all. So reduced ejaculation volume is not equal to complete retrograde ejaculation. I hope the point is clear. Because if it was complete retrograde ejaculation, the volume will have been zero. They say you have reduced volume. So reduced volume is not equivalent to complete retrograde ejaculation. It could at best be regarded as partial retrograde ejaculation. Right. I think there's another question. Let me. Right. Somebody is also that, okay, so in retrograde ejaculation, then urine can mix with the semen if the closure doesn't go on well. That is not exactly the case. You talk about this scenario when urine may mix with the semen. We call it climacteria. We talk about that one. This one, we're talking about the semen, instead of coming out, all right, as in antegrade ejaculation, it's rather going back. Okay, remember the mechanism for urination is different from mechanism for ejaculation. So here you're talking about where the semen, everything has been made possible for the semen to have come out. Instead of coming out, it's going to go back. All right, so that's a different mechanism. You talk about this mechanism where the urine is mixing with the semen in a condition you call climacteria, and you see that the mechanism is quite different. All right, good. Right. So how will a doctor, for that matter, a clinician, suspect that there is retrograde ejaculation? Preliminary diagnosis of retrograde ejaculation. So the doctor or the clinician must have a reason to suspect that. For example, a doctor must have a reason to suspect that you have, let's say, UTI. You can tell your story. Doctor will think, okay, I think you have UTI, so go and do urine RE or urine culture. Okay. So what are some of the conditions that can cause a clinician to suspect retrograde ejaculation? One, there will be reduced ejaculation. All right. So if the patient has been asked to go and do semen analysis, and then one of the parameters for semen analysis will be the volume. The volume is 1.0 or 1.1 or 1.2 or sometimes quite less than 1. The next time go and do it, the volume is still less than this thing. You will suspect. Any good doctor will suspect retrograde ejaculation. Any good doctor will suspect retrograde ejaculation. Right. Then there's also this dry orgasm, aspermia. The patient has been asked to go and do semen analysis. All right. He said, I've tried, I've done everything. Meanwhile, nothing is coming out. Okay. If you have any good clinicians, straight away you suspect that if you have tried, done masturbation, you have even done coital this thing, yet nothing is coming out, then it means that the semen is going somewhere. All right. And so that could also be a good suspicion for retrograde ejaculation. And then there's also cloudy urine post-orgasm. You know that, remember here, you are saying retrograde ejaculation, you are saying that all the semen has gone into the bladder. So once they go into the bladder, what do? They mix with the urine. And so when you, after sexual activity, you produce urine, and the urine looks very cloudy, then straight away that cloudiness could not be due to an infection. It could be due to the fact that there is retrograde ejaculation where semen went into the bladder and for that matter mixed with the urine. And so the urine that's coming out is a mixture of urine and semen, the situation that will also give a clear or strong indication that there could be retrograde ejaculation. If the sphincter mechanism is not functioning well in retrograde ejaculated, doesn't mean during urination, the backward seminal fluid doesn't come out with the urine. Remember I've said that the mechanism for urination is different from mechanism for ejaculation. Yes, the mechanism for urination is different from mechanism for ejaculation. So here we are saying that there's supposed to be a mechanism to control the semen from going into the bladder. All right. Now, that mechanism has failed. Okay, that mechanism has failed. It doesn't mean that the mechanism for urination has also failed. Please don't confuse the two. The mechanism for urination is different from mechanism for unless you have incontinence. No incontinence, when you have urinary incontinence, it means that involuntary, I mean, you have no control over when to urinate. And so the urine will be coming out. That's incontinence. And that's also a different medical condition. All right. So for as long as you don't have a problem of incontinence, it means that you can control when and how to urinate. That's why I said that mechanism for urination is different from mechanism for the ejaculation. All right. So during the urination, you have control. It is, how do I call it? Like I've said, unless you have incontinence. I'm sure you know incontinence. Incontinence where involuntary, you don't have control. I mean, before you could say that the urine is coming out. Okay. Otherwise, you have control over how to empty your bladder. And that should not be confused with retrograde ejaculation. With retrograde ejaculation, we say that all the mechanisms for ejaculation have been met. And we expect that the ejaculation or the semen should come out. Okay. And we say for it to be able to come out, because the prostate, and for that matter, the urethra serves the dual purpose for urination and then for the semen, there should be some regulation. Remember, when we were talking during the first day, we talk about the prostate being a gatekeeper, where it is controlling a switching over when the semen should come and when the urine should come. Okay, so we are saying that now all the systems have been set for sexual arousal, everything is happening, and now you have the semen being pushed into the prostate area. Okay, and from the prostate area, the next thing is the ejection. So, like we say, ejaculation is two principles, two phases. You have the emission, accumulating of all the products at the prostate area, and then pushing it out, the ejection. So in trying to eject, you must make sure that the bladder neck is tightened. Okay, it's tightened. If it is tightened, then there will be no way for the semen to go back, rather to come forward. And that's the normal ejaculation, which we call the antegrade. Now, if for one reason or the other the bladder neck fails to tighten or to close, then like I said, line of least resistance, then they will think that they have to move through the line of least resistance. That's go back into the prostate. Sorry, into the bladder. Please don't confuse at all. It is very, very simple. You saw that in ejaculation, the principle for ejaculation is different from the principle for urination. All right. Now, we're talking about a situation where the principle for ejaculation should be a lock to ensure that they come out and then come out forward. All right. So if that lock, there's a loose end there, then if the loose end is not too loose, then some will go into the bladder and some will come out. That's the situation where you get reduced ejaculation. If the loose end is so loose, then some will not even come forward at all. All of them will go back. So what I'm saying is that in that situation, semen will not even be, there will not even be low volume. There will be nothing like low volume. There's nothing at all. And that's what we call the aspermia or dry orgasm. The person feels that, oh no, I feel that I could get a feel that I've had an orgasm, yet nothing is coming out. And as you do this, I'm sure that one day, somebody will come to you where you come to do semen analysis, you have given content, you've given everything. You go and come back, say, with sweat, tell her, oh doctor, I've tried and tried. Nothing's coming out. A good lab scientist with a good knowledge of andrology should suspect that there's retrograde ejaculation. In that case, what you do is that you ask the patient to go and produce urine. You look at the urine and you see that the urine looks very cloudy. All right. So that will be your first suspicion. So once you are going to look at examination, the urine exam, we have what we call post-ejaculation urinalysis. All right. Or post-orgasm urinalysis. That urine, the physical examination is that just the physical examination alone will give you an indication that yes, there's potentially retrograde ejaculation. Right. Let me also look at another question coming up. So is retrograde ejaculation different from vas deferens obstruction? Quite different. Quite different. You see, you are talking about the vas deferens obstruction, which is also a possible cause of low volume. Now, remember we said that, like I said, if somebody comes to you with fever, I'm sure that before you think about, let's say, enteric fever, you will have ruled out malaria before, because malaria will be the commonest cause of fever. All right, so you rule out your malaria, you rule out malaria. And then if malaria, the person has fever, all right, then you rule out malaria is not there. Then you can now consider other things like the enteric fever and so forth and so on. So yes, when you have reduced semen volume, obstruction is a possibility. But the best or the commonest cause of the reduced ejaculation will be the retrograde ejaculation. I'm not saying that what you are saying is not possible. It's possible. But between the two, between retrograde ejaculation and then the obstruction, the retrograde ejaculation is more common than the obstruction. So you have to rule out the retrograde ejaculation first before you come to. If you do all the tests for retrograde ejaculation, it is negative, then you may consider, let's say, ductal obstruction. In that case, ductal obstruction, now you may have to go and do some ultrasound or even CT or something to confirm it. I hope the point is clear. So, yes, it is possible that it could be ductal obstruction. But between ductal obstruction and then the retrograde ejaculation, which is common? Retrograde ejaculation is common than the ductal obstruction. So I will not go in for ductal obstruction as my first condition to consider. How that point is clear. All right. So now you see, you're talking about preliminary diagnosis. There's reduced ejaculation, and for that matter, hypospermia, or there's dry orgasm where there's nothing even coming out at all. And then there's also cloudy urine post-orgasm. That is after the patient has gone to try and say, no, I've tried, nothing's coming out. So go and bring me urine. So the post-orgasm urine is cloudy. That's also a strong suspicion. So you are talking about preliminary diagnosis. All right. So these are the things that will help you to think that, oh, I think that I'm dealing with a condition of retrograde ejaculation. All right. So let us look at the causes of retrograde ejaculation. Like, so closure of the bladder neck, okay, and seminal emission are initiated via the sympathetic nervous system. I think we talked about this already. Just to recap, okay. So any factor which disrupts this reflex inhibits the bladder neck contraction may lead to retrograde passage of semen. I think this one we talked about it already. All right. This one you have described it. Retrograde ejaculation is associated with dysfunction of the internal uterus sphincters and blah blah blah. We talked about this already. Common causes of retrograde include conditions which cause nerve damage. Yeah, so I think we also talked about, and that is so. Retrograde ejaculation may be seen in medical conditions such as diabetes mellitus, multiple sclerosis, and then spinal cord injury. Remember, you said that in all these things, in diabetes mellitus and multiple sclerosis, there seems to be a neuropathy, nerve damage. And remember, you said that ejaculation and all those things are controlled by the sympathetic nervous system. All right, so if the nerves are compromised, if the nerves are damaged, then of course, ejaculation and all those things will also be compromised. So note that Ari, that is the retrograde ejaculation is often the first presenting sign of DM. So that's why if a clinician, if somebody goes to see a clinician that, oh, these days, even when I have sex, it appears nothing is coming. I don't see any sperms coming out. Any good doctor will rule out diabetes mellitus. Any good doctor will first ask the patient, are you a diabetic patient? If you're a diabetic patient, then you said, okay, if you're diabetic, have you been taking your medication? Because uncontrolled diabetes is what will cause all the neuropathies. If you control your diabetes very well, the neuropathies may not happen. The nerve damages will not happen. But if you don't control diabetes, it comes along with neuropathies. And neuropathies, one of the things that will be affected will be ejaculation and all the things. that depend on the autonomic nervous system. All right. So common surgical causes of retrograde ejaculation. Sometimes too, it's not a medical condition. Remember, if you have undergone an operation in the bladder area, there's a condition that was affecting the bladder, and there was surgery, and that also had something to do with the bladder neck. The thing that you remember, all these things we're talking about is the fact that the bladder neck should have the competence to close, to prevent retrograde ejaculation. So if you have had a surgery, then the probability of the bladder neck being compromised is high. For that matter, retrograde ejaculation could also occur. Colorectal surgeries, any all the neurons, that are associated with the what do you call it? The not the hypogastric region, the region below the umbilical, the umbilical cord, the region down there. Those areas control the nerves that affect your bladder and everything. So if there's any surgery around those areas, it's possible that the nerves could have been compromised and therefore could also cause retrograde ejaculation. Transurethral prostatectomy. Transurethral, where, when the surgery is going to remove the prostate, they could do an open surgery where the prostate could be worked on from the abdominal area. But here, there's a new technology where the transurethral, they pass something through the urethra to the prostate area without necessarily cutting through the abdomen. Understand? So in that case, it means that all the what do you call it? The neurons in that area could also be compromised. And then transurethral bladder neck incision. These are all, we are bringing this in up so that as a scientist with knowledge in andrology, if you have some of these clinical conditions indicated on the patient's laboratory form, then you could know that, oh, the patient has done this. Then it is likely that you could also suffer from this condition. That is why I'm bringing this up. Otherwise, these are not within our domain. But I'm bringing them up so that, for example, if they have written on somebody's lab form TURP, that's transurethral resection of the prostate. All right. So these are surgeries that could also compromise the patient's capacity to control semen, and for that matter, retrograde ejaculation is possible. All right. Now, this is our area, laboratory diagnosis of retrograde ejaculation. And we have what we call post-ejaculation urinalysis, PEU. In confidential, we have PEU as pediatric emergency unit. I'm sure nobody will confuse that one with pediatric emergency unit. So PEU is post-ejaculation urinalysis. And this, wherever there is, what do you call it? There is a presumptive diagnosis for retrograde ejaculation. This is a test to do. Post-ejaculation or post-ejaculatory urinalysis, PEU. So once the urine is produced after ejaculation, all right, like we said, sometimes we say post-orgasm. Post-orgasm because the person will feel that he has reached climax, yet the ejaculation, the semen did not come out. The coming out of the ejaculation, of the semen is the ejaculation. If you say post-ejaculation, then the person, somebody will tell you that, okay, what about in cases of complete retrograde ejaculation, where there is actually nothing coming out to show that there's ejaculation? So what then is the case? Then that will be post-orgasm. But orgasm is the feeling that reaching the climax that, yes, I'm satisfied. I think that the semen should come out. Remember, we talked about ejaculatory inevitability. Now, when we reach a certain climax, a certain point, whether the sexual stimulation or not, ejaculation is supposed to occur. So it means that ejaculation is preceded by orgasm. So if you get orgasm and nothing is coming out, it definitely tells you that the semen, the thing which is supposed to come out, has gone somewhere. And the only way, the only best place that you could go is into the bladder. All right, so that's why you are collecting urine. That I expected your semen to come out, it didn't come out. The next available place that you could possibly go is the bladder. So I'm now collecting urine, and urine will now contain, so the urine that comes out will be a mixture of the semen and the urine itself. All right, so we are saying that when we have suspected retrograde ejaculation, you do post-ejaculation urinalysis. And for all urinalysis, you do your physical examination, you do chemical examination, and you do your microscopy. Now, as we move along, you see that in this particular case, our physical examination will be the appearance. So the appearance will be cloudy. As soon as your appearance is cloudy, that is even, a better confirmation that there's possibly retrograde ejaculation. So you look at your physical examination. The physical examination is the appearance. So the urine that has come out post-orgasm is cloudy. So you put that one down, physical examination. With a chemical examination, here you're not going to look at your urine, sugar, protein, everything, because you want to suspect that you're suspecting your parameter of interest.